It just turned 7:35 here in New York City. So I'm going to do a share screen, and it's a pretty rudimentary slide deck just to help guide the conversation. And we'll go ahead and get started. And let me, so obviously the title of this is Obesity or Optimizing Obesity Care, Integrating Medicine, Rehab, and Fitness. So, welcome to what is hopefully going to be an ongoing series of webinars through the Medicine, Rehab, and Fitness Institute that Thomas, Sheila, and I co-own. And hopefully it'll be ongoing for about the next 100 years. That's our goal. 100 years worth of webinars. And so, yeah, thank you for joining. And what we're going to do, and by the way, even though I've been doing presentations for a long, long time, especially when it's webinar or in front of a camera, I'm just the worst when it comes to the introduction part. So just bear with me as I do that. As we get into it, and I'll be a lot better. But in any case, we're going to start with introductions and then go from there. So Sheila's going to start, and we'll move on from there.
Hi, everybody. I am Sheila Aubois. I'm a PA, physician associate is our new name. And I have about six years of experience clinically treating obesity in a cardiovascular practice as well as a primary care setting, and dozens of years before that doing health coaching, including weight coaching for a large healthcare systems employees. I'm also faculty at Shenandoah University in Northern Virginia. So I have a really big background in health coaching, and I bring that perspective to my patient care.
My
I'll
name
pass
is
it.
Thomas Hammett. Yep. Oh, perfect. Thank you. I jumped the gun again on my intro, man. So my name is Thomas Hammett. I'm a physical therapist by training. I currently serve as the director of operations for a company called Pinnacle Lifestyle Medicine. We are both a management and consulting company that works with a group of medical clinics, both private practice and hospital groups, on running lifestyle medicine services, including cardiac and pulmonary rehab, physical and occupational therapy, nutrition services, and medical fitness across various locations in the United States. What I'll say briefly is that, in my experience as a physical therapist, my introduction to really any kind of obesity medicine was the conversation I was having with my patients, where they would bring up to me almost passively, because I was terrified of the subject initially, particularly as a new grad, that, if I just lost 20 pounds, I bet my back pain would go away. And as a practicing provider, I was really unprepared to deal with that situation, and learned pretty quickly, practicing in a lifestyle medicine model where I had some unique resources, that there were some things that I could do, and ways that I could improve my practice that would really serve my patients. So I'm looking forward to sharing with you my experience and talking with Jeff and Sheila about this topic today.
And hey, everyone, I am Jeff Young, and I'm about 30 years into my career and have an extensive background with and working with obesity care. I have a bachelor's in kinesiology from Penn State. I have a master's in exercise and sports science. I'm currently a doctoral student pursuing an EDD in kinesiology, so I'm not going the PhD route. I'm going the EDD route. As it relates to my experience with, well, actually, before I even say that, I also teach as an adjunct lecturer at the City University of New York, York College in Queens, New York. I teach strength and conditioning. I teach nutrition and health, intro to sports medicine and rehab, and a weight training activity class. And my first job out of college was at Duke University Medical Center's Diet and Fitness Center. I'm not sure about the program now, but back then it was arguably the premier, or at least one of the premier medical weight loss facilities in the United States. I've also worked at UCLA Medical Center's Gonda Diabetes Institute and Beth Israel Medical Center's Freeman Diabetes Institute as a fitness educator, as my primary role in both of those facilities. And I was the founding fitness coordinator and faculty practice provider at a Mount Sinai facility here in New York City called the Center for Health and Healing. I was there for 10 years until they shut it down, unfortunately. And we evolved into the most comprehensive integrative medicine and medical fitness facility in the United States. At all these facilities, I also just directly collaborated with like endocrinologists and nutritionists, social workers, et cetera, et cetera. And I presented at the Obesity Medicine Association's annual conference earlier this year in Denver, and I'm currently collaborating with two of their state societies, chapter/society as well. So this is definitely like a comfort zone for me, my wheelhouse, exercise and obesity care. So I really look forward to our discussion. And I also just want to very quickly mention, just to make sure that not only is everybody here aware, but everyone who views the recording via our website. This is obviously through the Medicine Rehab Fitness Institute. And just want to make sure that everybody is aware that besides these webinars and the Medical Fitness Podcast, we offer all kinds of things which you can learn more about on our website. But the main thing to know now is that we offer coaching and consulting services, various educational services, and it could be anything from a combination of all three of us to pick your two that you want to work with, or we can work solo with any one of us. But we're happy to have those conversations and hopefully collaborate with people as well. So with that said, let's go ahead and get started with the webinar and the first question. And that is, what is our why? So Sheila, why would you say that we're hosting a webinar centered around obesity medicine?
The three of us representing these three disciplines believe that properly dosed lifestyle interventions, including exercise, really should be a first-line prescription for reducing body fat and reversing the secondary health effects associated with obesity. I'm not sure anyone would disagree with that. Our concern is the public and medicine specifically are increasingly turning to weight loss medications as the first-line intervention for obesity and not always including lifestyle counseling, especially these like telemedicine services where people are getting compounded medications shipped to their house. There's a concern that there's not lifestyle counseling going on with that. The third point I would say is the narrative around exercise as an intervention for weight loss has recently become, oh, it's not very effective. So we want to specifically to address that tonight.
And that leads me to another question for you. And that is, what information guides you when a patient presents to you with a goal of weight loss in the clinics that you work in?
Well, every patient encounter is unique. I think clinicians can appreciate that there's not just a little roadmap where we can follow a script with patients and, have them out of the door in 10 minutes after we've handed them everything to know. But there's certain things that I like to discuss that are pretty standard at every visit. So with every new patient, I start with a validated lifestyle assessment tool. I actually use the lifestyle assessment short form that's available through the American College of Lifestyle Medicine. I believe it was originally developed by Loma Linda University in California and tested there and validated. And it is it's a front and back one pager with questions about aspects of each of the 6 lifestyle medicine pillars. So nutrition, exercise, stress management, social connections, sleep, and substance use. And I like it because it also includes a brief depression and anxiety screening. And it asks the patient their why, like what motivates them for change, and also which areas they would most like to address together for our visit. So they'll rank them number 1, number 2, number 3. So before I even see a patient, I know why they want to get healthier, which areas they really want to talk about and work on. And there is a question on that screening about, I'm happy with my weight, I want to gain weight, or I want to lose weight. And if it's gain or lose, it's a lot, a little, they're able to say that. So that's really good information to have. I also like to get a weight history by decade. So tell me about your weight in each decade of life, before you were 10, in your teens, in your 20s, in your 30s. This helps me to know, is this been a lifelong struggle? Or is this something that happened, after having kids, or after, in a certain decade? And if so, tell me about if there's any factors that you would say correlated with that change in weight. So that's really good information to know. I also want to know what they might have tried in the past if they've tried losing weight in the past, and how long they tried that. Sometimes patients will tell us, oh, I tried A, B, C, and D. But if we really dug into how long they tried each of those, it was, I tried this one for a week, then that one for 2 weeks. This one I tried for 3 months. But as we all know, weight loss doesn't usually happen very quickly. And so it's a long-term consistency type thing. So it's important to know how long they've tried something and any successes they've had in the past. Often they've tried something and had great success with it in the past, but then the weight came back. Any challenges they've had in the past, what did they try and like? What did they try and dislike? And if they disliked something they tried, what did they dislike about it? Because certainly we don't want to recommend things that they've already tried and did not like, or we want to address those challenges. I also want to know how much weight the patient wants to lose and what they hope to be different from that. Like, so I keep asking why. Why do you want to lose weight? What is your reason? And then why that? And what's going to be different in your life if the weight is lost? And so I keep going until they're talking about improving their conditions. I want to get off of my blood sugar medications. I want to get off my cholesterol medication. I want to be able to move better. Like, it's really important to figure out tangible things, not just weight loss, because weight loss is not a behavior that they can directly control. I can't just send them to the corner to lose weight, right? So I want to get to the deeper whys so we can have some internal motivation for those types of behaviors that are going to directly impact those whys. So what are their health goals? And then we talk about, relevant past medical history, any surgeries, comorbid conditions that they might have, their social history, what their physical activity level is in life and at work, commuting, transportation, alcohol intake, any other substances, family history of diabetes or weight issues, especially medications they may be on. So I can look down the list and see if there's something that's increasing appetite, or causing sleepiness that interferes with their weight, supplements that they're taking. A lot of patients are taking a lot of different supplements. And then I also try to get in a question about openness to referrals. What kind of support, how much support do they think they need? Are they the type of person that likes to just get information and do things on their own? Or do they feel like they need a team? And if so, are they open to maybe, pulling in a dietitian, a physical therapist, or a qualified fitness professional, a behavioral counselor to address that type of thing? So lots of different information. I'm glad that I have 45 minutes to an hour for my first visits.
I want to add just real quick to Sheila's point. So in the meeting chat, that lifestyle assessment short form is a open reference. So you can access it through the link that I shared if you want to see what Sheila was talking about. I also just want to reinforce the point that she made. There's a point that she made about weight loss and weight loss goals beyond just the goal of weight loss and getting deeper into that. And I can't tell you, I feel like from a medical standpoint that it feels so simple, but it almost revolutionized the ability for me to understand what patients were hoping to achieve and got away from the superficial conversation of weight loss, weight loss, weight loss for the sake of weight loss. People have goals that go deeper than that. And we have to have those conversations if we want to identify what people might be willing to change and really understand the source of that feeling that is, I need to lose weight, but I need to lose it for, my family or my health or my XYZ. So I really appreciate you bringing up that point, Sheila. Really valid.
Thanks, Thomas, for putting the link to the assessment form in the chat.
Yeah.
So, Jeff, there's a general claim out there that exercise alone is not a very effective prescription to make for facilitating weight loss. How do you respond to this?
And for the attendees and the viewers of this, I'm going to go over several slides to answer this question. That's part of the reason why I put, is this even the right question to ask? Because I just think that we shouldn't think about exercise as just being for weight loss. There's so much more value to it. And so what I'm going to do over the course of the next several slides is just try to piece some thoughts together. And the purpose of this is not to teach a class. There might be some things that you're not very familiar with, but we can either talk about that at the end if you have any questions or something that you can dig deeper in with for yourself. But I think we need to start with the clinical definition of obesity being the accumulation of excess adipose tissue or body fat. And let me actually go back and say that obviously we're talking about the accumulation, the excess accumulation, where it's now in some sort of your body fat percentages in some sort of unhealthy range. And that leads to the cause of obesity. There are many, many things that influence obesity, whether it's pathophysiology, environment, your circumstances, upbringing, et cetera, et cetera. But the cause of obesity can be boiled down to chronically exceeding energy or caloric needs. And therefore, and the whole point of this really is hopefully not to argue about definitions or semantics or things like that, but rather to realize that the energy balance model, or in other words, calories in, calories out, is an important part of this whole equation. And obviously, physical activity and exercise represent the calories out part. And then people will say, well, but it doesn't show uh, that much weight loss. It's not that significant. And as you're getting ready to see in the upcoming slides, there's just way more to it than that. But the point here is that the energy balance model and calories in, calories out is part of the equation. We need to include it as part of the discussion and the approach, because it is math. There's one side of the fence and the other, and we need to be burning calories. But additional considerations include, and again, this is just going to be, I'm going to be rattling this off and we can talk about it in more detail later on. But the effect exercise has on satiety. So it's really important to think about that. It's not just about calorie burning. It's about the fact that it improves your hunger hormones and keeps you from feeling as hungry as often. And obviously then it has a positive effect on the intake side of the equation. There's something that I'm not going to go into much detail, but I at least want to mention it. You can look it up. It's something called the energy flux theory. The gist of it, as you can see here, a higher energy flux, or in other words, the more your physical activity and exercise, the more the output, or the calories out part of the equation. And what that does is it increases the body's capacity to process and utilize energy more efficiently, because you're regularly exercising and utilizing this energy, and the calories that you're consuming, so that your body's capacity to process and utilize it becomes more efficient. And what this does is it promotes a more stabilized overall metabolism, better fat oxidation or fat burning, and therefore it reduces the risk of weight gain. So the point here is that the model is important because it shifts the focus away from extreme calorie restriction and emphasizes how higher activity levels allow for a more sustainable approach to weight management, where energy balance is maintained through regular physical activity rather than drastic cuts in food intake. And then this also, another reason why exercise is so important is because of something called organ and system crosstalk. And the gist of it is that as soon as we start exercising, our muscles, which are an endocrine or hormonal system, release something called myokines, and then that it releases into the circulatory system and within cells and across interstitial space between cells, etc. And what it does is it causes the rest of our body systems and organs to start communicating with each other, because basically our muscles are saying to the rest of the body, we're doing work here and we need you to do work too. We need to get you to get better at what you're doing to help and assist us at getting better at what we're doing. So progressive exercise that leads to moderate to high fitness levels, you see that in red font and bold font for a reason, improves strength and function of all body systems. So exercise causes this crosstalk, and therefore it's a whole body systemic improvement in system function, which can then reverse or potentially heal common issues in obesity, such as hormone dysfunction, poor gene expression, and metabolic dysfunction. So the point here is that pathophysiology, poor gene expression, metabolic dysfunction, among other things, are not static states. They can become worse with additional weight gain and poor lifestyle choices, and they can be reversed and potentially even healed with improved lifestyle, increased physical fitness, and the associated loss of body fat. So a person is not stuck in their current state. And exercise is a huge part of the equation here, which is why we shouldn't just talk about exercise in the form of weight loss. It's way more to it than that. So in short, when the focus of exercise is on improving aerobic and strength fitness through a well-designed progressive program, it has a positive effect on other aspects of health, such as healthy eating, better sleep. It stabilizes your metabolism and reverses or heals pathophysiology and metabolic dysfunction. It improves satiety, aids in caloric control, greatly assists in weight loss, and due to its effect on metabolic stability, it reduces the risk of weight regain as long as exercise becomes a habit. So in conclusion, we need to focus on fitness. And let me just say that when I was at Duke Medical Center, which was definitely one of the better facilities that I've worked at, that's what we did. Like we had medicine, rehab, fitness, and behavior components, but the fitness component, we focused on increasing people's fitness. It wasn't just about getting them moving. Getting moving is ridiculously important, but it needs to include focusing on fitness. And when I was at Mount Sinai for 10 years, the facility that I worked at was called We Focus on Fitness at Mount Sinai Center for Health and Healing. So it's so important. And I think this gets lost in the discussion. We talk about moving more, we talk about exercise, but why aren't we talking more about fitness and really trying to improve both aerobic and strength fitness? So there's my little preaching sermon on the answer to Sheila's question. So I now have a question for Thomas after all. Go ahead, Thomas.
Actually, yeah, before you move on, Jeff, there was a question that I wanted to make sure I asked you in that section because I think it's
Sure.
important. And it's something we discussed before the call. So this is a
Ah,
hopefully a
yeah,
prepared
thank you.
question. But I think there's a lot of I would imagine that there may be a number of physicians that make the recommendation that walking is the best exercise you can do. And it was actually a question that I received recently directly from a cardiac rehab patient. And it was almost accusational. We were talking about resistance training, and it was in a group setting. And he said, I thought walking was the best exercise I can do. Why do I need to do resistance training? And I'm curious, if you were presented with that question from a patient, how you might respond, or from a physician who was trying to educate their patients better.
It would be tough to give an elevator speech response to that question and I wish that I like on the slide deck, I wish I had like a little image because the way I would approach it is to talk about that. First I'd start with the definition of exercise, and that it needs to be structured and progressive and, for the intent of improving fitness. I would then probably move from there to pointing out the fact that there are different fitness levels. There's beginner, intermediate, advanced, and elite. And that while, we don't necessarily need to be worrying about advanced or elite, that we should aspire to get out of beginner range. From there, I'd probably talk about the continuum of non-exercise physical activity or moving more, which is what is the category that walking pretty much falls into, which I really think is the main answer to your question, is that walking, we need to walk. I've lost nearly 35 pounds recently, and a lot of it is because I'm walking more. So walking is ridiculously important. And I have a pedometer and make sure I get my daily steps in, etc. So I'm not trying to make light of walking. It's so important, but it pretty much falls into the category of non-exercise physical activity or moving more and not progressive exercise that is focused on increasing, in this case, aerobic fitness. And it's also another reason why it's not going to, in my opinion, it's not the best form of exercise. It's a great form of physical activity, but not a great form of exercise because it's not going to improve muscular strength. It's not going to improve neural health that much. It's not going to improve bone density out of a beginner level. And so the governing body guidelines suggest that we need to strength train. So that's part of the equation too. So it isn't just about walking. It isn't just about aerobic exercise. We need to include all of the above: move more, exercise, strength train, progress.
Yeah, I really appreciate that. And I agree. For me, so much of my answer to this patient was trying to help get the understanding of the difference between physical activity and exercise. And for so many people, walking is not performed at an intensity that we would consider to be exercise in the way that it would be dosed or prescribed as. And if we're talking about exercise as a medicine, a casual walk isn't that. And we have to help people understand that. So I appreciate that. I wanted to make sure we talked about it before you moved on, but I know you got a question for me, so
Yeah,
go
no,
for it.
yeah, you're right, because we did talk about that before.
Yeah.
I knew I was going to forget it too, so I appreciate that you reminded me.
Yeah.
But yeah, now I'm gonna switch and ask a question for you. What tools do people with obesity need, in your opinion, to get started with exercise?
Yeah. By the way, I was on mute a little earlier because I got a 2-year-old who I think is walking around with a basketball out there. So I apologize if I get any background noise as I'm talking through my part. I'll try to minimize it, but we'll just do our best here. So Jeff's question is, what tools do people with obesity need to get started with exercise? And I would even say the obesity element of this doesn't make that huge of a contribution to my answer, though what I'll say is that people with obesity may have generally a more negative connotation of exercise in their past. Um, what we know current state is about 1 in 5 people meet the physical activity guidelines in general, and that less of those people um, do some regular form of resistance training. So there are tools needed because we're currently not doing what we would consider to be the minimum of health promoting exercise and physical activity. And if we ask ourselves why that's the case, we know that exercise is a behavior, and it's a behavior that needs to be regularly performed, which means that there are all kinds of barriers um, to making that something that is consistently done. And something that we know pretty much regardless of who you are, there are barriers that are just going to exist. And those are time and finances, and even really the social support um, of, feeling like you're supported by peers or, your loved ones in your home to get to exercise as a priority. And to me, if we decide that health must be a priority and emphasizes a priority, exercise is probably, in my opinion, it is the single most important thing that you can do to prioritize your health as a self-care behavior. So, in thinking about that set of barriers, the time, money, and social support side, how important is your health to you? And can we overcome those things by seeing how important this is? Again, this might be oversimplification, but in general, I want to say it's difficult, but we have to prioritize it. Now, there are other barriers that exist, and I don't want to ignore those because I think this is really where the tools can help. Um, these are barriers that I believe that can be navigated, which include pain and a lack of confidence with exercise or being in the gym setting, or whatever that lack of confidence around exercise may take in form, which it can take many forms. A general fear or lack of knowledge around exercise and how to do that on your own, and then a lack of belief in the process or the ability to stick with it due to the belief that exercise is actually going to benefit them. Um, and really, I think like this set of barriers, um, if we think about why people are deemed as having failed to lose weight with lifestyle interventions, it's that one or more of these barriers creep up and take over the process. In many cases, these barriers are not insurmountable, but we can't ignore them. Like, we have to commit to providing support to people who face these challenges, and remember that if exercise is part of a plan to support someone with obesity in either losing weight or promoting their health as a medical intervention, we have to provide support and recognize what people need from a support standpoint to be successful. So I want to address some of those the barriers that can be navigated, and the tools that you can use to deal with that. So if pain is the primary support or the primary barrier that we need to get around. And there's a lot of people, I mean, think about who I would see in physical therapy that can't work because of pain or injury. That may be the primary barrier to getting started with exercise. There's a lot of fear due to pain, and starting with a physical therapist or another rehab professional to address pain and improve confidence with movement can be a really beneficial place to start. I think something that even a lot of physicians don't know is that in most states, physical therapists are direct access providers, which means that you can see a physical therapist without a referral. And truly, if you believe that your patient is not exercising primarily because they're afraid of getting hurt, or they're currently in a state where they are hurt and they'd like to get back to moving. There's a lot of people who were previously on a regular exercise routine, get hurt, and then fall off track. And I have to emphasize the role of the rehab professional in supporting people in staying physically active. Um, if the barrier is confidence, fear, or a lack of knowledge, again, if we're saying that exercise is a priority and we feel willing to recommend something that would require a patient to financially invest a little bit in their health, that could look like working with a qualified fitness professional. This is something that I regularly do in practice. Our model is built around referring from physical therapy and cardiac rehab and nutrition services into exercise programs for people that are not currently exercising. And fitness professionals can provide support with getting started and even just the most basic education about how exercise can be safe, meaningful, and tailored to their needs. The last barrier that I want to address is a lack of belief in the process or themselves. What I would say about this is that there's a lot of things that we can do to teach people how to see progress in their health journey by showing them data around health change. This is something that fitness professionals can do. So it's something that they can self-monitor if they use like smartware, like Apple Watch or other wearable devices. But if you can see the data around your health change and be more informed about how you monitor your movement and behavior, and even the outcomes of having done so, it can be a really big game changer in building belief in the process and in themselves to be successful with exercise. And that's where I wanted to wrap that up. So, Jeff, how can we find fitness professionals who will be effective at helping people with obesity navigate these challenges and find success by making lifestyle change?
Yeah, the shorter answer to that is, fitness pros, you can find them either locally at a commercial like gym or health club, a medical fitness center that's like hospital based, or within a clinic like a physical therapy clinic or a wellness center local. So these would be options to look into. And then there's also virtual services, which we offer through the Medicine Rehab Fitness Institute, which is something that I just don't think a lot of people even realize is an option. But not only is it an option, but I am biased to believing and saying that really any clinic should include this as part of their patient services, because it's more schedule friendly, it's more cost friendly, and the way we set it up through the Medicine Rehab Fitness Institute is it's more for educational purposes to get people started off on the right path, rather than we do offer ongoing sessions if that's what the person wants. But unlike what you'll find in health and fitness clubs, where there's usually a desire from the fitness professional to retain the client for as long as possible, which can end up actually being a barrier to referral, because when the clinician says, "Oh, I think you should work with a fitness professional," they might in their mind be thinking, "I can't afford it. I don't want to do this for the long term, etc." So we actually offer something that's the polar opposite that people should consider. But as far as like how you would find somebody locally, I actually have for one of our podcasts, I created a solo podcast that answers that question in detail. So if anyone is interested in that and a much more detailed answer onto how to find someone locally, please send an email and I will link you to that podcast. If unless you want to look it up on our website and scroll down, you can find it, because there's various ways. There's uh, the United States Registry of Exercise Professionals is a registry with, I think, over 100,000 um, fitness professionals that are verified on that. So that's one way to go, the U.S. reps. But the bad thing about that is um, there's no headshot, bio, their experience, things that you would want to know. And then there's other registries and databases like through the American Council on Exercise, National Academy of Sports Medicine, American College of Sports Medicine, National Strength and Conditioning Association. Some are a little bit better than others, but the point is that there are registries. As a matter of fact, you could even go to, I think it's called neighborhoodtrainers.com. which has registries or database of trainers across the United States. So there's definitely ways to find local trainers. I'll end with this. There's still kind of a problem with that, and that is you need credentials, you need competence. In my biased opinion, you need vetted by someone who has the experience and knowledge to vet them, i.e., me. So I would highly suggest that you think about that as well, and rather than just hoping that a local trainer is good because they tell you they're good, send them our way to the Medicine Rehab Fitness Institute, and we have a vetting process that we're going to be collaborating with the Medical Fitness Institute on this in the near future, to just add that extra layer of um, confidence from your end and therefore trust that they really are competent. So, but again, if you're interested in the local side, if the virtual side, connect with us. The local side, connect with me, and I'll send you the video that I created, the podcast.
So
So,
we had one question in the chat, which Thomas took a stab at answering. But Jeff, we were asked, what wearables do you recommend for providers to be able to monitor what's going on? And I would just put my 2 cents in here that I do have a discussion with patients about whether or not they do want to see what's going on. Some are like, they don't want to know, right? Like they don't want to be stepping on things every day, twice a day, or whatever. Then I have the other extreme where patients want 7 different types of monitoring tools: one for their sleep, one for their breathing, one for their heart rate, all kinds of stuff. But it's cool. We're in a tech world where there's a lot of options out there now that are coming available. And I'm not an expert in all the options, but one thing I do think is cool is my cardiovascular patients who have internal devices like pacemakers and things. These now are giving us some data on their physical activity. So I've busted a few of them who told me, "Oh yeah, I've been walking and doing this and that, and I can see the flat line of heart rate activity for the last 3 months." And I'm thinking, well, whatever you're doing, either you're not doing what you're saying you're doing, or you're doing it way too low intensity because it's not bumping your heart rate at all.
yeah,
Yeah.
I'll say that this is a better question for Thomas than it is for me. So,
Yeah, Samantha, I really appreciate the question. And my answer very much reflects what I said in the chat, that we use an integrated platform through TechnoGym that, like, we have fitness professionals entering data in there. Anytime they exercise in our facilities or outside the facility, we can understand what kind of exercise they're doing and what their heart rate was while they were exercising. It links with Strava. It could be cost prohibitive to small groups. Like if you're a small private practice or an individual, it's probably a pretty expensive option if that's your goal, but a really good tool. And, I would even actually open this question to anyone else who's in attendance today, because I'm curious if as Sheila said, this is a world of technology right now. There's so many different um, kind of tools and technologies available for doing this kind of work. We use one that we feel really confident with, but yeah, I'm curious if anyone else has any input.
My Zones is in the chat. My Zone's great for user engagement.
Yeah. Yeah, we're familiar with MyZone too. Thanks, Aaron. This is a good time. I'm open to other questions or thoughts, right, guys? Anything else you want to add, Jeff or Sheila, before we?
no, I would love if we just open it up for any questions
Yeah.
for them. Any questions at all? Are you passionate about bridging the gap between medicine, rehab, and fitness? At the Medicine Rehab Fitness Institute, we provide in-depth resources to help clinicians collaborate with qualified fitness professionals and optimize exercise for everyone. Head to www.mrfinstitute.org to explore our full course on moving patients through this pathway and learn how you can add lifestyle medicine or medical fitness services to your practice. Visit us today to dive deeper into the future of exercise as medicine. One of the things I think about when it comes time to present these webinars is it makes me wonder what people's expectations were and why they, because you registered because you had some sort of expectation. And then when we're finished our little spiel, did we meet the expectation? So that's one of the things I'm always very curious about. What did you expect when you registered? Did we meet the expectation? And if not, then that that's actually to me why this is a perfect opportunity now to ask your questions to help
Yeah.
expectations.
So Jeff, Kara did ask a question around payment model with insurance. Kara, is there any one of us in particular, and hopefully this was clear in our introductions, that while Jeff, Sheila, and I work together closely on the Medicine Rehab and Fitness Institute, our day jobs are in separate locations for separate groups. So all three of us may have a different answer to that question. Was there one of us in particular you were targeting that towards, or all three of us?
Yeah. So the tie for the three of us is that we're three passionate people in three different industries who are trying to make a bridge between these three so that it becomes a tighter gel throughout the US and can push healthcare forwards, and not be so disjointed, and having providers not knowing how to connect our patients with fitness professionals and vice versa.
So it's basically an education. Are you
Yes.
like educational at this point? Okay.
Yes.
Yeah. Okay.
Yes.
And
I mean,
basically like referring each other and referring your patients to each other essentially, and then education.
oh, I am definitely referring all kinds of patients to Jeff and the other fitness professionals that he has vetted. I've
Mm.
had a great experience with that, with every patient I've referred who has engaged their services, and have had nothing but positive feedback. I
Great.
really like the model because, like Jeff said, it's not engaging in a years long relationship with a trainer. It's, getting some information from the qualified fitness professional up front. They help develop a routine that is personalized and tailored for that person. So it's better than just an app that somebody is using to come up with 10 exercises to do at the gym.
Mhm.
And even though it's not someone watching my patient exercise, I'm confident that I trust Jeff's vetting. I've met the trainers he's vetted, and they are taking into account my patient's medical history, their previous injuries, their desires, and all of that, those types of things. So it's people that I'm really comfortable referring to.
And I'll actually just add real quick and say that during my 10 years in the Mount Sinai system, it became pretty obvious to me that most of the patients who were, and uh, we had a wide spectrum of care. So we had family medicine, internal medicine, cardiology, orthopedics, physiatry, physical therapy. I could go on and on. So it was a wide spectrum of clinicians referring patients, and it became obvious to me over the course of time that probably somewhere around 90% of the patients who were referred were not looking for patients for the long term. And again, like I said previously, it was a barrier to referral. And so that's a really huge reason. And then we had the pandemic and everything went virtual, that's when the light bulb went off my head. And I was like, I really need to offer this as a service. And then another problem that's obvious that a lot of people just don't want to talk about is the wild, wild west fitness industry. And one trainer says this, the next says that, and so I'm avoiding that as well. I only staff degreed exercise physiologists or kinesiologists, and they're thoroughly vetted. They go through a training system so that we're all following the same concepts, guidelines, and principles. So in other words, they're an extension of me. And so that's the reason why I'd like to think that what we're offering through these virtual services is an outlier situation, along with the fact that it's virtual, so it's going to be cheaper, and we're educating people, and it's so much easier to schedule sessions with people, etc. So I just want to add that as well.
We have a couple more questions, but I want to recognize Nita, who's had her hand
Yes.
raised and is also like on a treadmill or something, which is super exciting.
So I'm an OBGYN from Flint, Michigan. I'm getting certified in lifestyle medicine because my patients are dealing with a lot of obesity throughout the women's health spectrum. And I come from a very under-resourced area. Flint, as everyone knows, the home of the water crisis. I'm looking for free resources. In the past, for nutrition, I was able to send them to the YMCA that had the pre-diabetes nutrition course that worked for my patients. Exercise is really hard because many of my patients who can't leave Flint are on a fixed income. So I'm excited about these ideas of virtual trainers. And but do you guys have any free resources? I'm learning lifestyle medicine to try and write the exercise prescription, and doing, if getting them to Planet Fitness for $10 a month is probably where most of my patients are in terms of, what they can afford. But any ideas or, an insurance, we try to get resources for them in the local. We have a local Crim Fitness Foundation that's doing physical fitness and getting free classes at gyms. I just want to learn more about any free resources that I could incorporate.
Jeff and Thomas, do you want me to start with that?
Yeah.
Yeah, go for it.
Okay.
I have a response for sure. But
Okay.
yeah, go for it, Sheila.
So, my cardiology practice is in a lower socioeconomic status city in Virginia. And one thing that I've had a lot of success with is doing shared medical appointments in the office. And Jeff and I are actually working right now on developing a model for those where we would have some exercise targeted shared medical appointments so that patients could come have a visit. It's going to be together in a small group, but we'll bring him in virtually to discuss exercise, and we're probably going to break it out into like aerobic exercise, strength exercise, flexibility, and balance as a third thing. But it would be an insurance covered visit because you, as the provider, would be the billing provider. You'd be there. It would just be that Jeff would be providing the exercise education or one of his qualified fitness professionals. But I think that's a great way to bring in, especially for people with like Medicaid, they don't have a copay. Medicare often they have a secondary insurance, so they're not paying a copay either. Now, in my specialty practice, I guess you're considered primary care, right? So your patients might have lower copays. In my specialty practice, sometimes some patients have a $50 copay. So that can, for commercial insurance, it can get kind of dicey with the copays for the shared medical appointments. But a lot of insurances, the patients love to come. They like the social support. They like the group aspect. You just have to, as a provider, document a regular visit with the health conditions documented, the comorbidities and things, and then have whatever the content is just kind of a bonus on top of that.
I will say, Nita, I very much appreciate your work. My wife is pregnant right now with our second, and very familiar with the phase of life in which you're talking about seeing these patients. What I'll tell you is, and this is, from my personal experience, but also from being on the end of, treating patients who are pregnant or, seeing patients in our clinics in this situation. I know in my wife's pregnancies that her physical fitness is directly related at any given time to like how she feels during her pregnancy, and her ability to exercise at some level that meets her where she's at has been so important in her experience of being comfortable in her body and feeling confident that she can continue to do the things she needs to do. And what, part of what I had said earlier is that cost and time are always going to be barriers for every single person on this call. It's always going to be a barrier. And I think we have to ask the question, do we give our patients the opportunity to make a choice, even if there is no low cost option? And I think we have to recommend those options that do cost a little bit of money if there's nothing free. And frankly, if it's something that we really believe will help them. And a lot of the time, even if it's just a couple sessions of virtual training to help get guidance on what kind of like resistance training or cardiovascular exercise is safe. There's so much misinformation around exercise for women who are pregnant, like so much misinformation, and just one or two sessions of fundamental education and answering questions that go beyond what you could learn in a YouTube video. Like, to me, I can't think of anything that's been more valuable for my wife in this experience than working with a fitness professional at times in her pregnancy. So I just have to advocate that. I know we do want to find low cost options, and that we should be sensitive to that. I also don't want to diminish the value of what this stuff can do for people in the situation that you're seeing them in. So, Jeff, anything you want to add?
The only thing I'll add, and it's going to be just from more of a general standpoint, is that here in the United States, about somewhere around 70% of people are walking around with chronic disease and or musculoskeletal conditions, and I just am really hesitant. Like we have free like proper exercise technique videos, but I'm just really hesitant to just give something free as though it's a one size fits all program I mean, I think I have a feeling, and I'm not a licensed clinician, so I might be wrong here, but I have a feeling that that's part of the reason why walking is such a common uh, suggestion, is because anyone can do it. Most anyone can do it. But from a resistance training standpoint, which is so ridiculously important, you need to take into consideration knee pain, low back pain, shoulder pain, hip pain, and all the comorbidities, and then all the precautions and special considerations that you need to consider when designing an exercise program that's anything higher than light to moderate intensity, that's up in that vigorous range, so that we all need to have every once in a while. So that's the reason why I'm hesitant. And it also just reminds me, I know I'm being a little facetious here, but I remember many years ago, like one of my primary mentors, very ridiculously fortunately, from the exercise science end, is Dr. Bill Kramer, who's widely considered the premier sports scientist and strength and conditioning researcher in the world. And I remember one time I was having a conversation with him and on somewhat of a related topic, and his response to me was, "Knowledge isn't free." And and so that's part of my answer to the question, is that I can provide some free resources to an extent, but when it comes to actual programming, you got to take into consideration overweight, obesity, all the comorbidities and musculoskeletal issues that come with it, and that means that it's going to be a little bit more complex than just giving someone a YouTube video or something like that and saying, "Here, this is going to work for you," because in a lot of cases it's not. So I know it's not the answer you want to hear, but it's my honest response to the question.
Sure. Great
There's
questions.
several other questions in the chat. First steps for prescribing physical activity for patients that I can provide as a provider. First steps. I mean,
Yeah, is Adrian still on the call? Adrian,
yes.
maybe it sounds like maybe you're a referring provider. Any other information that you could give us to help understand kind of where you're coming from?
Hi, sorry. I had to figure out how to unmute.
Oh, that's
Um,
great.
yeah, so like when I get my patients who like just say they walk, right? They're like, oh, I walk, I walk, I walk. I walk my dog. Okay. I can tell them the benefits of physical activity and exercise. So if I'm trying to get them to exercise and they say something like, oh yeah, I have this beach body workout at home, or I have, oh
Sure.
yeah, I have a gym downstairs, or whatever they say, like, what could I tell them as far as get maybe this amount of cardio, this amount of resistance, you're looking for this, are you getting to this? Just some general pointers to help them get started on a program, or if they want to create a program for themselves, like kind of what they're shooting for, maybe some resources they could go to.
Yeah,
I don't know.
I'll try to tackle this one. So we have to think about exercise, from either the aerobic standpoint and the resistance training. So we have to separate it in two different categories. From the aerobic standpoint, it's a lot less complex. Not that resistance training is complex in the sense that it's difficult, but it is more complex in the sense that there's more working parts. So looking at the aerobic side of the equation, it's the way I look at it is it's the FIT VP principle. So the FITT-VP. Let me first just stop and say, are you familiar with that principle?
No,
Did you say no?
no, I'm not
Okay.
familiar.
So F stands for frequency, I stands for intensity. The first T stands for time or duration. The second T stands for type, or what type or mode of exercise. The V stands for weekly volume. So that'd be your 150 minutes to 300 minutes a week. And the P stands for progression. So this is a fundamental principle of exercise, and it relates to programming. So that's, you know, you would want to become more familiar with the FIT principle. And then, since it's not rocket science, you could have a handout or something like that you can give to your patients, because at that point, then it's literally just having a discussion to fill in each blank. Start with frequency. How often can you do this and fit into your lifestyle? Intensity, from an aerobic standpoint, refers to like your heart rate in beats per minute, and also how hard do you feel like you're exercising, like from a how winded are you getting standpoint.
Mm-hmm.
And I could go on and on, but I have videos that I've created that are on our website that you can learn about those things, educational videos. And then from a resistance training standpoint, I have a whole series of videos on this. And let me also just, again, for your sake and also just for all the listeners, now or in the future, I was contracted out by a company for a corporate health program called LNG Canada, Liquid Natural Gas. It's a $40 billion clean energy company in British Columbia, Canada. And my primary responsibility was to create a very comprehensive educational repository on all things flexibility, aerobic and resistance training. And this is my intellectual property. So I have a lot of that content up on the website. In the very near future, I'm going to be turning it into like modules and a course. But all this stuff is up on the website. But I'll briefly say that from a resistance training standpoint, it's all about progression. And so you really just want to start somewhere. You first want to ease the person into it. And I just am a big believer in starting off on like a physical therapy like program in the sense that it's 2 or 3 sets of 10. I know I'm painting a broad brush here, and that not all
Yeah.
therapists do this, but generally speaking, 2 to 3 sets of 10, kind of a low, not a whole lot of exercises. In other words, low variety, low warm up intensity ish, etc. And then ease them into it. And then from there, it starts to you need to have it a little bit more structured. And like with anything, there's a learning curve. So the answer to your question is there's a learning curve, and for you and for your patients. But the cool thing is that exercise science is not rocket science. And as you learn this stuff, you're going to be like, oh, this makes total sense. So again, I would recommend going to the videos that I specifically set them up to move from to cover all this stuff. They're in layperson's terms, so anyone can understand it, and you'll start to see that, yeah, this makes total sense.
Awesome. That was a wonderful answer. Thank you.
Absolutely.
There's another question asking if any of us think that clinical exercise physiologists would ever be part of the healthcare spectrum as a qualified health professional in the near future, QHP. That I'm going to give that question to you, Jeff, since you're working on it.
Well, the answer is absolutely yes. So the American College of, and who asked this question? Where's that at?
That's Thomas Gamble. Thank you, Thomas, for asking this question.
Yeah. Yeah, so the American College of Sports Medicine's Health and Fitness Journal, the issue that's out right now, the September-October issue, is on the professionalization of the fitness industry. The answer to your question is yes. I would highly suggest looking at the articles. I co-authored a feature article in that particular journal, but yes, the Physical Activity Alliance has been working on this for the past 4 years, and they've been doing a lot of like from a policy change standpoint at the Capitol Hill level, et cetera. And so probably in about 2026, 2027, there are CPT-3 codes in development right now. And at some time in the next 2 or 3 years, fitness professionals who meet the minimum qualifications licensed clinicians will be able to bill for their services. So we're getting really close, and I think we're only about two or maybe 3 years away from it.
We are almost an hour in. I want to be respectful of people's time, but there's just a couple very quick questions left. Adrian, you also asked best tips on how to counsel people who say they just don't have time. For my people who are really putting up the time barrier, it's kind of a message to me that we don't want to talk about jumping into like a huge exercise program right now at today's visit. So I usually ask them if they are open to exercise snacks. And they're like, what's that? And so we talk about food snacks as being a snack during the day. And so exercise snacks are just these little movements that you can fit into your day. And I try to get them to do an exercise snack in the morning before lunch, and then one more in the afternoon. And everyone has done it. 100% success. They get to choose their activity. It could be desk push-ups. It could be taking a flight of stairs up and down. It could be taking a walk around the building. It could be 10 sit-to-stands. They get to choose whatever it is. They just do a snack in the morning and a snack in the afternoon.
And
I love that.
I'll add to that and say that we always want to think about exercise in the sense of progression. So exercise is built on principles just like anything else. And one of the primary fundamental principles is the principle of progression. So we never want to think about it in the sense of it being static. You meet the person where they're at, And if that's 5 minutes a day, since we're talking about time here now, right now, there's a topic. If that's 5 minutes a day or 10 minutes, and not even every day, 2 or 3 times a week, just meet them where they're at, knowing that probably what's going to happen is they're going to realize that they're starting to feel better. It's easier to climb the stairs, or their knees not bothering them as much, or whatever the case may be. And then you progress. So it's always think in your mind that you meet them where they're at, and then we're going to progress at their pace. The tortoise wins the race, but we always want to progress. We want to, move from one thing. You know what? Improvement. So we're going to improve on wherever they're at, and go from one stage to the next, one level to the next.
I think if I was to add one thing to this, time is very much a function of priority. And if someone is in what we would call in stages of change language, the pre-contemplation stage around thinking about doing anything, what I would ask of any of you who are medical providers is don't throw your hands up and say, "Ah, they don't want to do it, I'm not going to do it." Like, one, if they don't understand this is a priority, let's help identify if there's any objective information we can give them to help them see the importance of this. Like, truly, let's be as objective as we can and identify whether, the outcomes of exercise could feel like a priority for them to achieve. And don't back down. Like, I really think a lot of times when we get met with resistance, we kind of say, they're not ready for it. That's fine. If we can help people identify truly the benefits that this modality can have for them and their health, and move it somewhere up in their priority levels, there is time. There is always time. Time is the time excuse is the manifestation of it's not important. So how can we help bring a feeling of importance? And as medical providers, there's no better person in their life to help them identify that this could be an important change for them. So that's the last thing I'd add to that.
Yeah.
And I actually have one really important thing to say. Sorry about that, Sheila, but let me just interject and say, again, to you and to all the listeners now and in the future, this is actually what my doctoral dissertation is going to be on. So I just want to make sure if you're interested in collaborating with me, I would really appreciate it. Again, this is for anyone who's listening, because I want to be able to collect data on this, because what I'm going to do in the doctoral dissertation, the short version is take those first 3 stages of the behavior change trans-theoretical model: pre-contemplative, contemplative, and ready/prepared, and use intake forms and discussions as a way to determine which stage the patient is in, which will then help direct conversations, and then list all the barriers. Like, that's something that I can help you with. I provide all the barriers, and then solutions to those barriers, and get people to realize that many times there's not only solutions to nearly every barrier, but most of the time these solutions can actually be facilitators. So in other words, the barriers are actually perceived barriers, and once the discussion gets going, and it's an informed discussion, the clinician and especially the patient will realize, oh, I didn't know that. Now I've become informed, and that you can actually you can use their perceived barrier to facilitate exercise. So if you're interested in collaborating with me on this, via a data collection standpoint, I would really appreciate it.
All right, we have time for this one more question. We have a comment from Samantha. I think information on how seniors can get a PT on a regular basis would be helpful, and
Is
not sure if that's
PT
with Medicaid or Medicare. So that question's for you, Thomas.
is PT physical therapist or personal trainer, Samantha?
Physical therapist.
Yeah, so I would temper your expectations on getting PT on a regular basis, though what I'll tell you is that particularly for our patients with Medicare, they have really excellent coverage for physical therapy. You do not need a referral. They only need a signed plan of care, which is acquired after the first physical therapy visit, to be seen for physical therapy. And to be seen on an ongoing basis, there will need to be some kind of diagnosis like balance or um, a range of motion or pain limitation of some kind. What I would suggest to you, Samantha, is to think about, like, physical therapists really are experts when there is a physical health condition at helping people address that physical health condition. And if there's not a direct physical health condition that they are working with that patient on, they're not thinking about prescribing exercise for the benefits of like health promotion and longevity. Or, and with this conversation, we're talking about weight loss and people who are interested in losing weight. And if you were thinking about finding a personal or a physical therapist who could help, your patients who want to pursue weight loss, and the barrier that they're dealing with is pain, send them to physical therapy. They will have coverage if they have Medicare. Most of the time, they'll have coverage if they're Medicaid, though there are a lot of private groups that don't see patients with Medicaid because payment from Medicaid is so bad. This depends on the state, but it's an unfortunate reality that's just true. Most hospital systems do see patients with Medicaid, and you can get your patients referred to or sent to a hospital-based clinic like that. So I think that's what I'd want you to know. But then, work with a physical therapist that has a relationship with a fitness professional, or have one of those relationships yourself. Because the idea of exercising only when they are hurt or have an acute physical impairment often doesn't address the bigger picture of health that we're hoping to achieve when thinking about exercise for the purpose of weight loss or other health promoting goals. So hopefully that makes sense. There really is quite good coverage for those people. So sometimes, depending on where you live, there may be a long wait list and a shortage of providers. Unfortunately, that is true, but oftentimes good coverage, particularly for Medicare.
I would just add that we can refer to PT and put the primary reason for referral as obesity. And then someone like Thomas can actually do a full body assessment of that patient, versus if we just make the referral for knee pain because of the obesity, now he's limited in only treating the knee. So
Yeah.
just having kind of a broad referral, and then the physical therapist can do what they need to do to get the codes and billing all straight.
Yeah, there are very few payers that require a referral with a diagnosis code. So Sheila's absolutely right. I love getting referrals for hypertension and obesity and type 2 diabetes, because it does open the scope of what I'd be looking at and become more of a conversation around how your physical movement is limiting your ability to exercise. And again, just more of a health promoting conversation than specifically an impairment based conversation. So I really appreciate the question. Thanks, Samantha.
Yes, thank you all for joining tonight. We are going to have to head out and wrap this up tonight, but stay tuned for more webinars and tune into our podcast. And we'd like to encourage you to visit our website. I did put it in the chat, mrfinstitute.org. Consider taking one of our courses. We have a whole course on obesity.